I have no disclosures related to this topic. There are actually surprisingly few data, but the best data is very long-term, and it comes from the Syntax trial, 10-year all-cause mortality in the Syntax trial based on the presence or absence of calcium and stratified by treatment strategy, so PCI or bypass surgery. These are high-risk patients, and this probably is no surprise, but these are the 10-year data that presence of at least one heavily calcified lesion actually markedly increases all-cause mortality. Now, all-cause mortality, because these patients are higher risk in many different respects. If we go back to that baseline characteristic slide, which I won't because I won't have time, they have other features. So it's not just cardiac mortality and cardiac adverse events, it's all-cause mortality and other issues, kidneys, etc., that makes it the more higher risk. So this is stratified by whether the heavily calcified lesion is in the left main or whether it's in the context of three-vessel disease. So you can see that the high 10-year mortality in patients who were in the trial who had at least one heavily calcified lesion in the left main versus three-vessel disease. And in fact, if you had no heavily calcified lesion, then left main or three-vessel disease had equivalent results and quite reasonable. Let's look at those with heavily calcified lesions, whether they just had one or at least two or more heavily calcified lesions. The highest risk of mortality was in bypass patients who had more diffuse heavily calcified disease, and the least with PCI with one heavily calcified lesion or bypass, which is equivalent. But this is an interesting observation that bypass surgery and diffuse heavily calcified disease did not go together very well in terms of outcome. So this actually tells us again, that if you had at least one heavily calcified lesion, if you had bypass surgery, you had the highest risk of dying, all-cause mortality at 10 years, followed by heavily calcified lesion and PCI, and no heavily calcified lesion, bypass surgery. Patients did the best in that regard. So again, these are high-risk patients, so patients who have heavily calcified disease, which is, as you can see, an important independent predictor, also tend to be more likely to have peripheral vascular disease, COPD, medically treated diabetes, etc. So it is definitely an independent factor, but is associated with other significant comorbidities that raise the risk of long-term adverse outcome mortality. More recent data obviously don't have as long-term outcome data. This is by Tarantini from the Rolex study, so this is quite recent and with one specific stent. As we can see in this registry, prospective registry, at least a few patients had no calcium and mild to moderate calcification, almost 2/3, and severe in 12%. So that's the context I will present that in. And this is the one-year data. Target lesion failure was quite low, cardiac death 2.7%, all-cause death 6.2%. So patients undergoing left main PCI, this is pretty good, and as you can see, the majority of these patients had some calcification in their left main. Obviously, a ROTA paper is going to have patients with calcium, so this is an analysis by Boisset and colleagues looking at 1,000 patients treated with rotational atherectomy, 171 of whom had their left mains treated with rotational atherectomy. Again, very high-risk features in all of these patients. These are older patients, so left main, rotational atherectomy, 76 years mean of age. And as you can see in all these regards, the patients with left main calcium, i.e. rotational atherectomy, have more adverse features at baseline than do patients who have non-left main rotational atherectomy, i.e. calcium. But the results are actually quite reasonable, quite equivalent. As you can see at 1 year, all-cause death, almost 13% in left main, severely calcified lesions that required rotational atherectomy. So again, these are kind of more modern results with more modern stenting. Let's look at a few cases. This is a 52-year-old man with prior PCIs, multiple PCIs of the circumflex artery. As you can see, what looks like some calcification, moderate to heavy perhaps. As we can see, this is really a 111, 011 to 111, I would say 111 bifurcation lesion. If we look at, okay, so I'll run both of them and I'll speed this one up so you can see the calcium in the LAD and heading into the left main. Left main itself was not that heavily calcified. So in this particular case, and the circumflex had the multiple stents, wasn't too bad, so we proceeded to a strategy without plaque modification based on this with non-compliant balloons only. And so we did pre-dilated the circumflex and pre-dilated the LAD both with 3.5 by 15 NC balloons. Then that was the result. We elected to go with the DK crush technique here. So this is our 4.0 stent that we're positioning. 4 by 15. We deploy the stent. We immediately do a pot after stent deployment. Actually, I usually do higher pressure inflation by withdrawing the balloon a little bit just to make sure that there's optimal result at the ostium. Then it's important to do a pot. I'll discuss this later on today again, so I won't go into too much detail on that. 5 by 8 NC balloon. We recross. Proximal recrossing is critical in the DK crush, unlike in provisional stenting where you do a distal recross. So here, because if you do distal recross, you may actually go abluminal relative to the stent and actually end up with no stent in the distal part of your ostial vessel. So important to go proximal to mid. Balloon recross, 3.5 by 15 balloon. I'm not a stickler in this case for NC versus no NC, as long as I don't go high pressure and go beyond what the diameters of my branch vessel. A non-NC will always cross more easily than an NC balloon. But with the pot, it actually makes it very easy to recross. There are very few instances where you cannot recross to dilate through the struts of your vessel. So high pressure inflation, first kissing balloon inflation. We position and deploy a stent in the main vessel, in this case to the ostium because it's a short left main. We recross it, we do a pot, immediately do a pot again, so second pot at this point. Again, to ensure that you don't wire abluminally now relative to the left main stent. And this wire recrossing I felt was too distal, so I did it again and went to higher pressure this time and low pressure kiss. There's never any need to do high pressure kissing balloon inflation. Low pressure is what I usually do, and this is our final result. I have another case, but obviously I've gone on way too long. This is a more interesting case. Suffice it to say, the IVUS was beautiful in the LAD in left main. Maybe I'll just, so here's our, as we go to the bifurcation, you see an excellent result. There were actually no protrusions whatsoever of stent material into the bifurcation. I think this has already been shown. This is critical intravascular imaging, especially in calcified left mains, but any left main intervention is critical. I'm out of time, so I won't show you this case very much. This was a case where we used lithotripsy, shockwave, and to success. Let me just quickly show you how this ended up because we're out of time. lithotripsy, and in this case, a T-stent.
Dr. Dzavik, may I request you to summarize? We need
Yeah.
3-4 minutes to discuss also.
Yes, yes.
Yeah, please.
Absolutely. Thank you. I think I'm the first one who's been asked to summarize, but I'm happy to do so because first time, that's great. So, final result. Okay, and to summarize, and thank you for prompting that. The presence of calcium in the left main artery portends a high risk of long-term adverse clinical outcomes in patients undergoing left main revascularization, whether it's PCI or bypass surgery. In fact, evidence suggests even more with bypass surgery. Meticulous technique is required to ensure best patient outcome. That includes intravascular imaging, optimal lesion preparation, and POT. I can't overemphasize the importance of proximal optimization technique. Calcified left main should be performed in facilities equipped to deal with complex anatomy and the complex patients, which means everything. And again, as alluded to by my colleague previously, if you don't do left mains, don't do left mains. I'll quote that forever from here on in. So thank you very much.